Hello viewers, this is Dr. Rajiv. Welcome to your education channel, YouTube Surgery and Orthopedic Education. Please consider subscribing it as well as share it to your near and dears to help them in their preparation of MBBS course as well as other postgraduate and job entrance examinations. Also, please don't forget to press the bell icon below so that you never miss an update from us. In the last talk, we discussed a common breast condition, nipple discharge. Today, we shall talk about another common breast condition, breast infections and inflammations. Breast mastitis is associated with lactation in most cases. Hence, it is also called lactational mastitis. Lactational mastitis is the most common type of breast infection. It is associated with breastfeeding during few weeks of parturition. Lactational infections are most often caused by a gram-positive bacterium, Staphylococcus aureus. The entry of bacteria occurs through the nipple into the duct system. They manifest as cellulitis with breast parenchymal inflammation and swelling termed mastitis or as abscesses. They are characterized by fever, local erythema, tenderness, and leukocytosis. The infants are intermediary agents in transmission of infection because after the second day of life, staphylococci are found in nasopharynx of 50% of infants. There is a relatively high incidence of mastitis in women with a retracted nipple. Ascending infection from a cracked nipple also may initiate the mastitis. The diagnosis is clinical and usually straightforward. Early on, there is a generalized cellulitis, but later an abscess may form. In the cellulitic phase, the patient can be treated with an appropriate antibiotic such as flucloxacillin or cotrimoxazole, along with breast support, local heat, and analgesics. Breastfeeding may continue from the affected site so long as the mother is not concerned. If an antibiotic is used for prolonged period, in the presence of undrained pus, a large sterile brownish swelling termed antibioma may form that takes many weeks to resolve. Hence, the breast should be incised and the infected milk collection drained if the infection did not resolve within 48 hours. If a frank abscess forms, repeated aspiration is usually successful. Formal incision and drainage under local anesthesia through a radial or circumareolar incision is necessary if there is marked skin thinning above the abscess cavity. Breast tuberculosis or tuberculous mastitis is a rare breast condition usually associated with active pulmonary tuberculosis or tuberculous cervical adenitis. Its incidence is less than 0.1% of all breast conditions in Western countries and 3 to 4% in tuberculosis endemic areas such as India and Africa. It usually affects young lactating multiparous women. Most commonly, the disease presents in the form of multiple chronic abscesses and sinuses with a typical bluish appearance of the surrounding skin. Fine needle aspiration is the most widely used initial method for diagnosis of breast tuberculosis. The gold standard of diagnosis of breast tuberculosis is by bacterial culture or histological examination or by Gill-Nielsen staining of breast tissue obtained from FNAC. Treatment is with the standard anti-tuberculous drugs. The breast tuberculosis can be diagnosed when both epithelioid cell granulomas and necrosis are present on histological examination in the sample of FNAC. Actinomycosis is characterized by abscess formation, tissue fibrosis, and draining sinuses. It causes a chronic, invasive, progressive, and often relapsing granulomatous infection. The causative agent is a gram-positive, facultatively anaerobic rod-shaped bacteria belonging to the genus Actinomyces. The breast is very rarely affected in primary care and breast clinic settings. Mondor's disease is a type of thrombophlebitis that involves the superficial veins of the anterior chest wall, breast, and the arm. Its cause is unknown. Frequently affected veins are the thoracoepigastric vein, the lateral thoracic vein, and the superficial epigastric vein. The pathognomonic feature is an acutely painful thrombosed subcutaneous cord-like induration over the lateral aspect of the breast or the anterior chest wall that is usually attached to the skin. A narrow, shallow subcutaneous groove forms alongside the cord when the skin over the breast is stretched by raising the arm. Its diagnosis is largely clinical. The only treatment required is putting the ipsilateral arm to rest and taking analgesics if the pain is troublesome. The condition usually subsides within a few months without recurrence, complications, or sequelae. In non-lactating women, a chronic relapsing form of infection may develop in the subareolar ducts of the breast, termed as periductal mastitis or duct ectasia. This condition is more common among smokers and diabetics. Larger lactiferous breast ducts are dilated and filled with green fluid which may present as a greenish discharge from the nipple. This condition may be complicated by subareolar mass, abscess, and fistula formation. A carcinoma must be excluded by mammogram and negative cytology or histology. Eventually, fibrosis develops, resulting in a slit-like nipple retraction. Treatment is antibiotic therapy and surgery in the form of major duct excision or Hatfield's operation.